It's a pleasure to be with you all. My name is Ishani Ganguli. I'm an assistant professor of medicine at Harvard Medical School, an internist, and a researcher in health services. I'd like to introduce my distinguished panel today. I have Dr. Eliana Perrin, who is Bloomberg Distinguished Professor of Primary Care in the Department of Pediatrics in the Schools of Medicine and Nursing at Johns Hopkins University, an obesity prevention researcher, and a practicing primary care pediatrician at the Harriet Lane Clinic. And I have Dr. Jessica Colburn, an assistant professor of medicine at Johns Hopkins University, medical educator, and a practicing primary care geriatrician at the Johns Hopkins Bayview General Internal Medicine Clinic. So I wanted to start with a couple of comments about this setting. So I am really excited to be here with you all at the National Press Club because I got my start in journalism, and in many ways that led me to primary care. So I wrote for my high school and college papers and first got interested in medical journalism through an internship at ABC News Medical Unit. I was writing about topics in epidemiology and technology, and in parallel, I was training to be a doctor. I went to med school, and as my clinical training progressed, I started to notice and write a lot more about the challenges I saw in healthcare delivery, and all the challenges with rising healthcare costs and the quality that we get that's just really not up to par with the spending that we do. And realized that the gap was really not in lack of cures or lack of technology, but in the gap between knowledge and execution. Started writing more about these issues and also got the chance during medical school to understand primary care a bit better and how it was really linked to some of these solutions. So I remember, going into my continuity clinic in med school and realizing that primary care was just really fit my generalist personality. I loved that there was such diversity of cases. I got to see, knee pain one moment and an unexplained headache the next. Diagnostic mystery. I got to see the doctors I worked with have these longitudinal, really deep, sustained relationships with their patients, and I wanted that for myself. And so at the same time, it was right around the time in med school that the ACA, the Affordable Care Act, was being signed, and realized that some of what I'd been writing about and seeing in primary care practice was really showing that primary care was the solution to a lot of the problems that we were thinking about, right? So really being framed as a solution to rising healthcare costs and a solution to the quality gaps that we have in healthcare. So with all of that in mind, I applied to primary care residency. I was lucky enough to land at Mass General, and Dr. Blumenthal was one of my early mentors. And flash forward to today, I study primary care payment and delivery in my research job, and I get to practice primary care for my patients. So our charge today is to think about the value of primary care and across the lifespan. And so I'm so lucky to have my colleagues here who think about patients across that lifespan. What is that value of primary care? So this was articulated a bit before, but we think about the value in terms of what Barbara Starfield made famous in terms of the 4 core functions, right? So there's first contact, access to primary care. So your doctor or clinician is that first person you turn to when you have any kind of a symptom or a question. They're your person. Second concept is continuity of care, that interpersonal relationship that really sustains and builds trust and is in both directions. So you know your patient knows you. Third idea is comprehensive care. Your primary care clinic is where you get most of what you need. And we always are willing to refer out if needed, but really that's the place to take care of your whole body. And the final idea, of course, is coordination of care. So whether that's across different specialists or across care settings. Your primary care clinician is the quarterback or the conductor, or whatever you want to call it, the person who's sort of managing and being the team leader for your medical team. And primary care and these core functions have been linked to a lot of really positive health outcomes, right? So there are studies linking primary care to greater receipt of preventive care, chronic condition management. We see an association with lower total spending at a per capita level, less use of low-value care. We've done a study looking at health systems, and ones that have a greater share of primary care doctors use less low-value services or services that have no net benefit but can harm patients. We also see a recent study from Sanjay Basu and others in 2019 found a really compelling link with mortality benefits. So he and his team found that for every additional 10 primary care doctors per 100,000 Americans, there was an additional 52 to 118 days of longevity, and specifically reduced mortality with cardiovascular disease, lung disease, and cancer. So really compelling benefits. And so with that in mind, let's think a little bit about how this value plays out in these various settings. So I'm going to start with Dr. Colburn. Can you tell us a bit about how you articulate the value of primary care in the geriatric population?
Thank you very much. Thanks for having me and for inviting me to talk about this. So I came to fall in love with primary care as a first-year medical student. So at the University of Pittsburgh, in the early months of my medical school training, I followed my mentor, then Dr. Andrea Fox, on a house call for a patient who lived only 3 blocks from the hospital. We actually could see her building from leaving the hospital campus. But she lived on the 3rd floor, and she was bedbound related to strokes and dementia. And so prior to enrolling in this house call program, the care she received had been only from the emergency department, even though you could see the clinic, the hospital, from the window of her home. And so the geriatrician who I followed that day went to her home, and we, carried her backpack and her supplies up to the building. But what she really did is sit and listen, and with her complex, kind of expert geriatric primary care bend, helped the patient's son make choices that transitioned this patient to staying comfortable at home, which is what she would have wanted and what her son wanted for her. But hadn't found another way and hadn't had a person, like you described, kind of help them think about this, a one trusted person to help them guide through the process. And so for me, that was kind of revolutionary to think about, that one could use their communication and expertise in a way that would prevent more things from happening that someone didn't want, as opposed to seeking out expert technology and things that someone did want. And so I think that really made me fall in love with this idea of management of complex patients at the end of life in geriatrics. And I think the value proposition in older adults is not hard to grasp, right? I mean, the costs in the last 2 years of life are astronomical. And I think we know from models in geriatric medicine, such as home-based primary care, for instance, that we can reduce costs, we can reduce hospitalizations, and without worsening survival for older adults and keeping them home where they want to be anyway for many older adults, that the expensive care isn't always aligned. So I think the value proposition in geriatric medicine, especially for highest risk, most expensive older adults, is certainly there. It's just, how do we build these more robust models and the ability for patients to access their person or their team at the times when they really need to not end up in the hospital or the ER, and to reach the patients. The first tenet you mentioned is access. And if you can't get in, or you can't figure out how to get someone to come to you if you're high need, then that certainly limits the rest of the steps from there.
Thank you, Dr. Colburn. I think also about the roles of polypharmacy, and I'm sure that you spend a lot of your time taking off medications from your patients' lists and coordinating care across the many specialists that older adults often have.
Yes, I mean, sometimes we talk about polyspecialist as part of that, that not only too many meds, but too many specialists. And I think sometimes it's helping people figure out, when do they need a specialist, and do they need to keep seeing them, or can they get an expert consultation and then come back to primary care? But yes, when we think about age-friendly health systems, the things we think about are the 4 M's. So what matters most: medication, so limiting those, mobility, maintaining function, and mentation, thinking about cognition and mental health. So yes, all of those.
Dr. Perrin, the benefits in your population maybe play out over a longer timeline, but are there nonetheless. Could you talk a bit about what you're seeing in the pediatric space?
Yeah, so in pediatrics, and first of all, thank you for inviting me to this conversation. I think pediatrics sometimes gets left off the primary care conversation, and I think it's just what you're asking about right now, which is that the value proposition is incredibly strong, but children are very inexpensive. Even when they're sick, they're inexpensive. And so it's hard to prove that value proposition. You need models that go way out. And if I and my colleagues are doing a really good job in primary care pediatrics, they're going to be less sick adults. They are going to need less of those pharmaceuticals, less of those specialists later on. But it's going to take a while till we see that. And so my particular area of research interest is obesity prevention. And we know from a whole series of studies that once children are 3, 4, and 5, those BMI trajectories are hard to reverse. That's 3, 4, and 5 years old. And so we really need to be thinking about prevention earlier and earlier. And so one of the programs I'm involved in is working with parents of newborns and helping them to not start some of the behaviors that later get entrenched and are hard to reverse. And so we actually got inspired for some of this work from talking with parents. And one of the parents said to me, I wish she'd never started the juice habit. Now she's hooked, but it would have been far easier if she hadn't started in the first place. So I and my colleagues are the providers that get to say not to start in the first place. And we get to do that over a whole range of health behaviors. But it takes time, and it takes lots of visits, and it takes building trust. And even when we're doing really, really well, we can often have a tough time of proving the benefit, even though the face value is incredibly high.
Thank you. I think it's clear from our conversation even early on that the value proposition for primary care has expanded beyond the traditional office visit, right? We've talked a little bit about home-based care. And so one thing we found in our research is that primary care visits have gotten longer. There's more we discuss more during the visit. We're trying to pack more in. There's less follow-up after those visits. And so sort of in tandem, a lot of the care has shifted outside of those office visits as well, where patients are reaching out to us through secure messaging. Thanks, Dr. Blumenthal, for that. But also through virtual and phone visits. And this all predated COVID, but has become even more prominent with COVID. And I think we can all sort of point to some challenges there and some benefits. And I wondered if you could each speak to the role of telemedicine or really more broadly, non-face-to-face care has played in your care of your populations. Do you want to go first?
Sure. So, obviously pros and cons with each of these additional technologies. And I'm certainly a fan of the 21st Century Cures Act and all that it has done for patient transparency. But boy, has it made the role of the primary care provider harder. That pajama time has just increased exponentially, and the ease with which we can be reached makes it difficult to have the work-life balance that then makes our profession attractive to go into, that then reduces the number of people in the profession. So I think it's a mixed bag. I also think that the return of results to families and to patients, while good on so many levels, again, increases the workload for the primary care provider to explain each and every test result when it isn't always given in a literacy level or in a language even that the family speaks. And so those things increase burdens. Telehealth, again, tremendous potential to reach people, especially those for whom the walls of our clinic may be unnecessarily high, and able to reach people in different settings that have suffered far too long from systematic disadvantage. And so again, such incredible promise. But many of us in pediatrics, for example, went into pediatrics because we love playing with kids in the exam room. We love sharing our stethoscope with them and having them listen to our hearts. We love having them draw on that crinkly exam paper. And so, those are some of the magical moments in pediatrics, and frankly, some of the moments where I think we are better able to assess children and their development and their interactions with families in a much less, in some ways, much more authentic setting, in some ways less authentic setting than telehealth. I will, given that I've given telehealth maybe a few negatives, I will share one just delightful story, which is that I had met with a family numerous times, particularly an adolescent girl who I had seen for numerous visits. And on telehealth one day, she said to me, she's like, "Oh my goodness, Dr. Perrin, because of telehealth, you get to meet my grandpa." And she proudly took her iPad over to where her grandfather was sitting in a wheelchair. And her grandfather's like, "Oh, hi. And it was just this beautiful moment. And so I do think for us in the future, what we need to figure out is for whom are those visits working especially well? Where do they create those magical moments and where do they take away? And that's going to be a challenge of primary care in the future.
Yes, I think so. We similarly have seen in geriatrics or in adult medicine the expansion of the hours and the ability for patients and their care partners or caregivers to reach us. And in some cases, especially for especially complex older adults, that after hours access, not necessarily to your own PCP, but to a robust team who's affiliated with your PCP really can help to prevent hospitalization, can help to prevent people from taking over-the-counter medications that are dangerous for them because they had a chance to ask someone before they tried a new sleeping medicine, for instance. So some of that access is really important. And we're finding in the pandemic that older adults do use telemedicine. You know, you'll hear ageist things about how older adults can't figure out how to use the iPad or something like that, which generally, certainly there are access and equity issues around Wi-Fi access and tablet access and being able, and we need to be mindful of those. And certainly there are access issues around people's comfort level with technology that we had to be attentive to. But you know, there were experiences also where, so for instance, a patient of mine who has fairly advanced dementia, who coming to the clinic for the patient and her daughter who do not live in the catchment area of our house call program is quite challenging. Even dropping off her mom close enough so she can go park is risky because she's not sure if her mom will wander while she's parking the car. And so telemedicine gave me the chance to evaluate the patient and then to let the patient in her own environment wander around her home while I could meet with her daughter and talk more about the questions and concerns she had. So I think there are certainly great opportunities for those. And certainly, as I mentioned, home-based medicine, not quite telehealth, of course, but an essential role in caring for homebound and functionally impaired older adults. And when I was doing house calls during the pandemic, you know, to mention to Dr. Perrin's point, I had a patient who was actually assisting her grandchild with her virtual learning at school. So, you know, when I would come in, she was going over like coins in math class with the granddaughter on the video while I was waiting my turn to examine the grandmother to go over her medicines and those kinds of things. So I think we sometimes see an appreciation over telehealth and home-based care, of course, of these complex family systems and the way that our patients are interacting with others that really help to inform their health care also.
Thank you, Dr. Colburn. We've just published a study looking at challenges getting to office visits for Medicare beneficiaries, and 1 in 5 say that they have trouble getting to the doctor's office. And these are patients who are more likely to have dementia, for example, or to have mental illness. It's not just functional impairment that leads to this. So it really does speak to this challenge of, you know, there's access issues with in-person visits as well, right? And these are also patients who are more reliant on caregivers to bring them to the visits, accompaniment, et cetera. So really some promise there. I want to maybe draw one distinction that I think about maybe in my younger adult population as well, which is that there's also commercial telemedicine, right? So there's these entities that you can get a one-off visit for, let's say, increasingly Paxlovid for COVID or treatment for a UTI, and that has its role for sure. I think that we want to draw a distinction though between what that is and what telemedicine or non-face-to-face care within the context of a usual primary care clinician is, right? And it's sort of what we're describing here is really drawing on those 4 core tenets of primary care and drawing on those continuous relationships to be able to offer it with different modalities. And I think there's a huge value to, as you're talking about, to secure messaging. For example, a lot of my patients come and, you know, they have a rash that they're sending me a photo of and wondering what to do. And it's, you know, it's really valuable to patients. And I think, as the two of you have really pointed out, the key is to be able to find a way to do that and support that work using new primary care payment models, because our current models are sort of treated as unpaid work. And not that we don't want to do it, but it really makes it hard to be sustained. I also want to point out that I noticed that we're all women on this stage. It turns out that female doctors tend to get more of these messages and tend to spend more time in after office hours. And some of it may be societal expectations of female doctors. Some of it may be female doctors sort of having inherently different traits, but the idea is that this also contributes to some inequities in the primary care workforce and burnout. And so all of these considerations are really important as we think about incorporating telemedicine more broadly into primary care going forward, which is, it's just going to be part of our care, so we have to do it thoughtfully. So turning to the idea of teams, we mentioned this before, and I think teamwork is such a big part of why we go into our fields, right? I think it's a real strength. And in one sense, teamwork is about, our multidisciplinary teams of physicians and NPs and PAs and medical assistants. I also am struck by primary care, offering a unique vantage point into social determinants of health and the role that neighborhoods and other factors play, and therefore the need for us to partner and be in part of larger teams with other institutions and people to try to improve on these social determinants. So I wondered if each of you could speak a little bit to that and how that plays out in your fields.
Sure. So absolutely. I mean, geriatrics, by its nature, along with primary care, but certainly for management and complex older adults, is a team-based sport. So we rely heavily on our nurse practitioner, PA colleagues, social work colleagues, community health workers, and also even beyond our clinic itself onto the into community-based organizations we partner with. So part of what we've done, we are fortunate at Johns Hopkins to have a funded HRSA grant through the Geriatrics Workforce Enhancement Program, which focuses on geriatrics partnering with primary care organizations and community-based organizations to really think about how to embed core geriatrics principles into geriatric workflows and geriatric teams. And so ways we think about this, for instance, are the care of older adults with dementia. So there aren't enough geriatricians or geriatric psychiatrists or neurologists to take care of older adults with dementia. That is owned by primary care and will be even more so in the decades to come. And so how do we train teams so that the nurse who does triage calls, for instance, knows how to coach families through that process? Or so that the front desk person knows when someone calls back 3 times to ask for their appointment, that might be a red flag that someone's having memory problems and that should be brought to the attention of the primary care clinician. So some of it is within teams. And then we also think about teams kind of outside the hospital and accessing community-based resources. And one example of this is a study that was done by Sarah Zanton, my colleague at the School of Nursing, called Capable, which is actually investing healthcare dollars into housing as solutions for healthcare problems. So what they did in that project is have a nurse, an occupational therapist, and a handy person work with an older adult who typically was of low financial resources in Baltimore City, so referred patients living in poverty, who would identify a healthcare goal they had, such as being able to leave the home for church or being able to come downstairs from the second floor to access the kitchen. And then they would use the skills of the handy person to make adjustments to the home, fixing holes in the floor, putting a double handrail for someone, for instance, adding the front steps. And they found that they were able to, for under $3,000 per participant, delay placement in nursing home, reduce hospitalizations, really enormous financial benefits, along with personal benefits, functional benefits, quality of life benefits, joy benefits. And so I think these are kind of examples of how we can't solve these problems as teams within healthcare alone, that we need to partner outside, and that primary care can't own all those things, but that our teams can't only be based inside to solve some of the problems our patients have.
Those are some amazing examples. We too in pediatrics, very much are reliant on the teams in which we work and are trying to find creative ways to engage multiple partners in the care of our families, particularly those most vulnerable. I think of 2 examples in the primary care pediatric space. One is a program that we're fortunate to have at the Harriet Lane Clinic at Johns Hopkins, which is formerly known as Health Leads, but is now known as the Hopkins Community Connection. And what it is actually undergraduate students at Johns Hopkins who are trained as resource advocates, who can be responsive to social determinants of health screening from our patients. So our patients answer questions about how housing secure they are, how food secure they are, whether they need additional assistance with a variety of areas of daily living. And then these students are trained to connect them with resources, including food, diapers, housing vouchers, et cetera. And so it's a really remarkable program, and it's embedded within the clinic. And these students don't just meet somebody for one day, they handle a caseload, and they basically follow up with families and make sure that they actually connected with services. So it's a really nice adjuvant to primary care because so many of us are dealing with healthcare problems that are really a result of poverty, racism, and other factors. And so anyway, this is an amazing resource. Another one that I think about a lot in pediatrics is integrated mental health care. And is no surprise, I'm sure, to the audience, just what an incredible mental health crisis we're in right now. It depends on where you are as to how integrated that system is, but certainly so many of us in pediatrics are relying on social workers, psychologists, psychiatrists, advanced practice partners to help us with the mental and behavioral needs of children. And so many children are feeling incredible anxiety right now, depression, issues related to being in school and then out of school and then back in school. And, you know, the transitions of our crazy world right now have really landed squarely on the shoulders of children. We have got to be creative about how to support. And we have found that when these personnel are on site, it creates a much better situation for families. They know where to go to the pediatrician. So they're not needing to find a new child psychologist, a new social worker, go to a whole new setting. And then the communication back and forth between pediatrician and social worker and psychologist can be all the easier. So those are two team-based models that I think are wonderful.
How does this play out in geriatrics, the mental health integration specifically?
Yes, I think also we are seeing really high need there in the pandemic in particular. And I think for many of our older adults, again, also there is both kind of an access issue, so getting to a new clinic like you described, and also not only for older adults, but generationally speaking, there's often a stigma portion of it. I mean, we see this at all ages, of course, but so the idea of kind of going to psychiatry clinic is sometimes a barrier that for some patients is hard to get over. And so having the integrated, so in our clinic, we have a behavioral health specialist who is integrated within our clinic who I can refer my patient to for short-term, typically short-term therapy only because there's only one of her. And so she can't manage all of our patients and often can't see them as often as they need. But I think even having that much access has shown us what a great need it is. She's supervised by a geriatric psychiatrist who helps provide backup for more challenging concerns, or if a patient discloses they're suicidal, for instance, that she has psychiatry backup for some of those things. And I think the other place we really see a need for integrated mental health in geriatrics is, as I mentioned, in dementia care. You know, the growing number of older adults and the growing number of older adults with dementia means that we really need systems to support those needs, the behavioral manifestations of dementia, the wandering, the other kinds of challenges that caregivers have and need support for. So both the caregiver burden and the strain of that for caregivers, but also the coaching for how to manage some of those behaviors. And some of our community health workers have been trained, for instance, in substance use disorder, in other things which are very high need, but not in dementia. So thinking about how do we make sure they have enough of the geriatric skills and also addressing the rise in substance use disorders and other mental health needs that we have in our clinic. So a really important part of our integrated teams for sure.
I'm fortunate to work in a clinic as well where we have mental health integrated in. And so in our setting, we have one psychiatrist across our clinic who is embedded and we can turn to for questions. And we have a social worker in every sublet of our team. We have, for every 4 or 5 doctors, there's one social worker. And it really is this incredible model where I feel very comfortable with mental health because it's something that I see a lot in my population, and I have the support and resources to be able to get help when I need it. Going back to this question, I think more broadly, we're talking a lot about how sort of primary care has expanded in scope. And I think it's hard not to sort of note an irony there because primary care is already so broad, right? And we have such limited time in a given visit to address everything we need to address. And yet, because we are the witnesses to so many of the challenges that our patients face that are not primarily about health, that are so related to their health. I can't help but think about gun violence today, especially. What is the role of primary care? Can we talk a little bit more about sort of I don't want to say draw the line, but how do we think about the role that we play and how that relates to others, other sort of spheres, social spheres?
So I think, especially today, as you mentioned, I think we in primary care have both the unique privilege and I think the burden of really being the front line witnesses. And I say burden not because, but I don't want to do it. I certainly find huge value in this, but because it is so much to carry how much our patients are facing right now, and as Dr. Perrin mentioned earlier too, the systemic injustices and systemic racism that are impacting our patients, that I think one of the things I've talked a lot actually with trainees about just recently is how do we embed this in our work? How do we think more about the fact that we should be advocates and leaders and activists because we see the ways that this work impacts our patients? And so primary care cannot possibly carry it all. I mean, like you said, there's more and more and more, that the expansion of our scope and the things we need to carry while also not having longer office visits to have all of those discussions and more kind of expanding beyond the day. And so thinking about ways to manage those, while I think also thinking about how do we partner with, not own, but partner with other organizations and aligned advocates for the issues that impact our patients so closely. So housing needs, insecurity, gun violence, the impacts of poverty, the other ways that our patients, that talking about their cholesterol medicine isn't coming close to addressing these other issues that really need more systemic solutions to them.
Yeah, one of my old colleagues, man by the name of Paul Wise, says pediatricians are the ultimate witnesses to failed social policy. And I think we certainly see that in pediatrics every day. And I think it is a great privilege to be able to help families with that. It's also obviously the source of incredible sadness because we see how these failed social policies play out in the lives of children that we care for. I think it is our absolute mandate to do as much as humanly possible for the kids, recognizing that we are in a much larger system and that so many of their needs are created from forces upstream. And so we can have as many workarounds to poverty as we want in clinic and give out cribs and overgarments and diapers and housing vouchers and connect them with medical legal partnerships. And what is really needed is different social policies. So primary care can get pretty all-encompassing, to answer your question. And I think various people draw the lines in different places. But I think, I don't know a primary care provider right now who hasn't expanded scope to deal with what's been going on in the world.
Yeah, thank you. I'd like to turn our attention now to the primary care workforce. We've talked a little bit about trainees. Many rightfully ring alarm bells about lack of medical students and residents choosing to go into primary care specialties, right? And that's related to factors that are specific to training. For example, we have relative underexposure to primary care as early as college and medical school relative to specialty care. There's always this sort of undercurrent of, well, if you're smart, you should go into a specialty. Sometimes it's subtle, sometimes it's just overt, right? We've all heard this. There's also just the structural barriers. So yesterday I was precepting a resident, it was a primary care resident who decided to go into cardiology. She's wonderful, and she was really thoughtful. We had a conversation about why that is, and we were talking about how she left cardiology because she had a chance to really immerse herself in it and felt like she got good at it after spending time in the CCU. And in contrast, when she's in primary care clinic, it's these one-off experiences. She's not immersed in that experience. She's always rushing from something else to come to primary care clinic. We also know empirically now that the patients that are seen by patients who are seen by primary care residents or medicine residents tend to be more complex. They often are bouncing from resident to resident, and it's a really challenging experience sometimes for these residents. And there's also just the fundamental issues with primary care that we've all talked about. There's underinvestment in the field, and there's devaluing of primary care relative to other fields. There's a real tension at the same time between calling out these challenges in the field and trying to convince these residents to go into primary care. It's a little bit of a vicious cycle. So with all of that in mind, I thought we could sort of focus on the positive here, because there is so much joy in practicing primary care. I think we all feel that. So I'm curious for each of you to talk a bit about what you say to your residents, your medical students, about why they should go into the field or why you did.
Sure. So, I mean, it's absolutely the best field, so that's the reason.
Yeah.
No, I think that we actually have to get back to what I was just talking about, which is the social determinants of health. And there's a real generational interest right now in social justice and social determinants of health. So my own two boys are 17 and 21, and neither one of them is remotely interested in going into medicine. But their friends who are, and they themselves are all interested in social determinants of health. They're interested in housing insecurity and food insecurity and social justice. And if you're interested in those things, what you want to do is go into primary care, because not a day goes by when you won't be immersed in that, trying to help your patients with that. And it is actually, for those of us who really love primary care, I think we really love that. We really love helping them with health issues that aren't just the biomedical health issues, but are the biopsychosocial issues that brought them to care that day. We also love preventing problems. And so for people in pediatrics, I mean, it's such a wonderful opportunity to prevent health conditions and health problems. So I always talk about that as well. And so those are the two things that I would say. I also, people go into various specialties based on who their patients are. I also tell students and trainees to also go into specialties based on who your colleagues are. And I have found that my fellow primary care, and particularly pediatrics, because that's where I've spent a lot of my space, couldn't ask for a more wonderful group of people. So the nurses, physicians, social workers that I have met through pediatrics, I mean, what a joy. So.
Yeah, so I think, one of the reasons people will ask me about primary care in general. They will ask me about geriatrics and the overlap between geriatrics and primary care, since geriatrics is, by nature, additional subspecialty training, though most of geriatric medicine is still a generalist approach to care. And what I often say is that I feel like I came to medicine both with a deep interest in individual people's stories and really coming to understand who people are and what's important to them, and also the complexity of the science, the logic problem of medicine, the trying to figure out why something is happening, and how you overlay these two things together, how you help someone choose the things that are most important to them for where they are at that point in their life, and for what medical problems they might be facing with the resources they have, with the resilience and individual strength and fortitude they bring, and with the barriers that they're facing, and how to do all of that. And there is just no place that is more alive in medicine than in primary care, the ability to overlap those things and to work with patients longitudinally. And I also think, to highlight what Dr. Perrin said, just yesterday, I was precepting also in primary care clinic with the residents, and one of the residents was saying to me that the news was just coming in from Texas at the end of clinic, and one of the residents was saying to me that she's just so angry, that our patients are facing this, and that there isn't more that we can do societally. And she said to me, like, how do you manage keeping your professional identity separate from your anger and activism and need to feel that you're doing something to work for change? And I said, I don't. I think that the reason that I do this work is because I can align them closely together, that I can be more of an advocate, and that I can think about what's really facing my patients and how to make my career every day, both individually and systemically, meaningful in the impact that I can potentially have. And so I think, the opportunity for our trainees to see those things in us and to see the ways that we work for them, and the fact that we do need to work together to make it a more sustainable field, I think gives them hope that there's possibility there too.
Yeah, absolutely.
I think there's a couple of things that we could do within training, though, to indicate value that we do not do. So, for example, I haven't been a continuity clinic preceptor at any site, and I've been a preceptor at 3 different institutions where there isn't always a priority on getting the residents from primary care clinic to wherever they need to be by 5 o'clock at the hospital that night. It doesn't matter what they're doing in primary care, what patient they're seeing, whatever. It's more important that they get to neonatology, the emergency room, whatever. And I think when we convey that, when we say, oh, well, we have to get you out so you can be on time to that, when there's never a priority to getting on time to primary care clinic, I think we do convey to some extent our value on primary care as being lesser than. And similarly, when someone in primary care is sick, they don't call in jeopardy the way they would with a subspecialty. And so, I haven't at a place where they do, so it's not institutionally, it's just sort of baked in our culture that we should be able to figure it out. But I think when we do that, we suggest that it's less valuable. And I think if we're all working together to share how valuable it is, and clearly the panel here and probably much of the audience has bought into that value proposition, then other things naturally follow.
Yeah, the other point to add to that is that this came out of the conversation yesterday with this resident as well, is that it takes time to get good at primary care, right? So when you do, I'm thinking of internal medicine residency, which is what I did. At the end of those 3 years, I felt really good about being a hospitalist because that's what I was doing day in and day out. And it's no wonder there's a study that just came out by folks at ABIM and others that a growing share of general medicine graduates are going straight into hospital medicine and staying there. So about 71% as of 2018. And it's no wonder because it's, again, what you're comfortable with, it's what you know. Whereas primary care takes much more time to get good at, because we don't give residents immersive experiences. They're doing this as one-off. And because primary care is just the long game, right? You're seeing these cases play out over not just one hospitalization, but over weeks, months, and years. Those relationships take time to build. And so how do we really show that value and that joy in a structure that's not really set up to show the benefits of primary care? It's a real challenge, and I don't know that I have an answer. The other point I was going to say, and maybe to think more about something you said earlier, Dr. Perrin. So I think that there is a ton of overlap, right, between social determinants of health and primary care. But I also want to be careful about not conflating them. And I think, not that you were doing that, but I think that that's something that often happens in choices that residents make. So I've seen, and again, this is my perspective as somebody who trained in a primary care track within internal medicine, that a lot of people sort of relate to primary care because of the link to social determinants, and people often have that value system when they're going into a primary care track, and then end up subspecializing and still being interested in social determinants. So I think that they're very related but distinct entities, and so creating tracks for people who care about those issues within any specialty, if you're going to do it, do that well, but then also celebrating primary care for the clinical specialty that it is, and all of the joys of the clinical medicine as well is really critical, I think. So my next topic is COVID, which of course is still very much on our minds, and I'm so happy that we're all masked here today. COVID shed light on so many things, but one of them was just, as Dr. Blumenthal referenced earlier, is that the critical yet deeply underappreciated and under-tapped role of primary care. I'm thinking back to those early months when I, like many of you in this room, spent so many hours on the phone with my patients trying to figure out, is this the time when they do need to go to the hospital, or can we stay at home just a little bit longer? Monitoring pulse oximetry, trying to figure out testing early on, and then later on, we're now in the stage of trying to get Paxlovid out to patients. There's just so much that happens at that intersection. And I think you described this in an article, Dr. Perrin, so we're at sort of at the in-between point between public health and hospital care in this sense. Our job was to keep patients out of the hospital so they weren't overwhelmed, but the prevailing narrative understandably was on that hospital care, ICU care, and that's what people were really talking about. And so I wonder if we can talk a little bit next about the role that primary care did play or should have played in the COVID pandemic, and what might have been different if it had. I'll let you, whoever wants to start.
Okay. So I think one of the ways that we saw this at our own institution is, as everyone remembers in the early days of the pandemic, as our hospitals were filling up and we were just starting to learn more, is that there was an all hands on deck kind of approach for managing the intra-hospital care. And so we were having division meetings about how we were going to be pulled from other clinical services and other work to cover hospitalist shifts, to back up hospitalists who were running COVID units and those things. And really our division had a meeting in kind of saying, like, wait a minute, our value here, though we certainly can go and figure out how to learn how to admit patients on the inpatient unit, is in keeping patients out of the hospital and helping really complex patients monitor their pulse ox and knowing when they should go, in knowing where they can get a test so they aren't flooding the emergency department for a test alone, in getting complex sick patients out of the hospital when they no longer need the hospital care, but they need someone who can follow them in a team-based approach on the outpatient side. And so we were really kind of rolling up our sleeves saying, how do we do that? And one example is we had a pilot initiative in partnership with our primary care clinic, our home-based medicine group, and our palliative care team that we called Home GPS, the Geriatric Palliative Care Service, where we had older adults who were electing not to be hospitalized in the pandemic because of the isolation from their family members. And so things they may have elected to be hospitalized for before, but the fact that they had to go in alone and worry that they might die in the hospital with their family unable to come in and see them was really a huge barrier. And so we in a combination house call and telemedicine approach, started seeing patients at home who our clinic was referring to us to say, this patient is ill and doesn't want to be hospitalized. And some of them with COVID, so we would go in with PPE, and some without COVID. We had a patient, for instance, who fell and was falling more often and having progressive, actually lower extremity paralysis. And it was likely he had either a tumor in his spine or a fracture that was impacting it, but he didn't want to go and leave his wife. And so we cared for him at home and ultimately transitioned his care to comfort care at the end of life. And part of this is because family members couldn't go in, which is a whole other conversation, but part of it was also meeting older adults where they were at that point in their life, at this point in time, at this era. And that was a skill that was uniquely primary care based in these longitudinal relationships, and uniquely geriatric medicine based with our colleagues, that we could do that. And so But we hadn't gotten a call from the hospital that said, like, hey, primary care, could you really help us with this complex need? We got calls saying we have an Excel spreadsheet with shifts to fill, right? And so thinking really about what our strength is and what we can offer at the times of greatest need, I think is really important. Two other things that we did. One is we had students who were doing calls, direct outreach to our primary care patients on behalf of the clinic, both for screening. How were people doing? Did they know how to get a mask? Did they know how to get hand sanitizer? Did they have questions about COVID? And also ultimately in vaccine outreach also, that patients who have real reasons to distrust the healthcare system as an overall because of its disparities and inequities still trusted, many of them, an individual physician. And so in those relationship contexts where they could ask questions and think over time about what felt right to them, we were able to help patients ultimately decide for themselves that they wanted the vaccine. So that felt important too. And I think now we're still caring for COVID itself, of course, but also really primary care is where we care for all the aftermath of this, right? The grief, the loss, the long-term disability, and all that people are facing as this is ever evolving and we're seeing what comes next. So, and that also is housed fully, I think, in primary care.
I think vaccination is such a good example of where it's really, that's what we do, right? All three of us spend so much of our time convincing patients to get the flu shot, and you in pediatrics even more so.
Yeah.
And so it really felt, I remember sort of feeling just really on the sidelines in that whole discussion about rolling out the vaccination and really wanting to help, and sort of like you described, sort of calling individual patients to try to tell them about these vaccines, but there wasn't a systemic response, which I think would have been really, really impactful. Dr. Perrin.
Yeah, no, such a thoughtful response. I'll just add a few sort of pediatric specific things, which is that prior to COVID, a lot of our business was runny noses and cough. And so in those early months, a lot of what I and my colleagues were trying to do was to try and figure out which were the ones that were COVID and which were the ones that were typical childhood illnesses, because there are so many lookalikes in pediatrics. It's really our bread and butter. And so that has been a challenging chapter from the beginning. Early on in the pandemic, when we were discouraging people from coming to clinic, one of the terms we used was unnecessary. And I wonder if we'll ever get back from declaring certain types of care as unnecessary, because we did for a good chunk of time not see people over the age of 2 for routine health preventive services visits. And the thought was that younger than 2, we needed to be have active eyes on heights and weights and give out vaccines. But that over the age of 2, this was a little bit more deferrable. And yet, I think we have unfortunately seen what happens when people don't come into healthcare, and probably more in your population than mine, but mine to a large extent too. Children, it turns out, the pediatrics visits are a really nice set of eyes and ears on kids prior to entering school. And during the pandemic, lots of people weren't even in school. And so that inability to sort of witness children as they were going about their lives, I think has caused a lot of ripple effects. And they are ones that we in the pediatric profession are still very much dealing with. I referred earlier to mental health, but can't emphasize enough how much of a big deal it is for this generation of children and adolescents. I was just talking to a pediatrics colleague the other day, and he said not a day goes by these days that he doesn't send somebody to the emergency room. And so, wow. I think that we have really seen what the chaos and the havoc has done to kids. And I think to not be talking to them throughout, to have so many of them coming back to us now after 2 years of deferred care is problematic. And we're seeing an incredible rise in the obesity epidemic. an incredible rise in anxiety and depression, and we're going to be living out the second, third, and fourth waves of COVID for a very long time.
Thank you. On that note, I wonder if we can take questions.
Any questions? Okay. Thanks for really interesting comments over the last hour. By background, I'm a transplant pulmonologist, so I guess maybe I'm part of the problem, I think, with a lot of the things that you guys are talking about. And one of the things that I really wonder is how specialists, particularly those with primary care roots, can be helpful back to primary care doctors, other than just things like make sure I send you the letter or whatever. What are the things, the levers that we can pull to make sure that our patients who have access to a primary care doctor are not losing components of that continuity by virtue of the relationships they're forming with us, especially in high touch point specialties like transplant or oncology or whatever?
Thank you for that question, and thank you for being here. I feel like that's already, you're doing more than many specialists. It's amazing. I guess you spoke to the issue of communication, and I think that's so key. Think to the extent that primary care is, our jobs are to be the team leader, whatever that means, sort of having those touch points. And I think we often talk about teams, multi-specialty teams, or rely on primary care, for example, in an accountable care organization model, to coordinate care between different specialists. But there's not actually that sense of team, because you might never have met the other people you're working with, right? And it's all through, staff messages and in Epic, for example. And so that communication goes a really long way, and really, even doing it personally, not just sending the notes. The other thing I would say is that primary care, we talked a little bit about the beginning about how it's defined by these core functions. So one definition is specialty, the specialty go into, but really primary care is more of a state of mind and a state of practice. And so for some patients, I think as a transplant pulmonologist, you probably play that role for your patients sometimes as well. And then that's okay. And that's actually really valuable. And so sort of I guess expanding our notion of what primary care means for a specific patient in a specific setting. I'll let you answer as well.
Yeah, just an additional point. First of all, great question and so thoughtful. The only additional point I'd make is that for a lot of hospital-based providers and specialists, we do in pediatrics get contacted on the back end. So when you're sending the patient out of the hospital, there'll be a nice discharge note, occasionally even a phone call, which is great, provider to provider. It would actually be really nice on the front end as well. I heard that from one of my colleagues who's been in the trenches of primary care pediatrics, day in and day out for 30 years. And she says she can count on one hand the number of times that a hospitalist has given her a call as the primary care provider to say, what else can you add to the story? And she feels like she's seen these kids for, sometimes 10, 15, 18 years when they're hospitalized, knows every issue they've dealt with since, the first grade or since they were born or whatever, and to not be asked what else she could contribute to the story. Sometimes she feels like she has to seek someone out and say, you really need to know about this because it's really going to affect their hospitalization, or the family is really concerned about this, and some things that could actually save some time. So I would say making sure that communication is both not just back end, but front end.
Yeah, and I think in geriatric medicine, so a few things. One is with our internal medicine residents, actually at Johns Hopkins Bayview, we started an initiative on our inpatient service that's focused on, the whole curriculum is focused on knowing the patient as a person, but one of the components of it is that the team reaches out to the primary care physician on diagnosis or early in the hospitalization as part of that. What more can you add? What else should I know? And sometimes it shortens hospital stays because the PCP says, oh, I can take it from here. Thank you for what you've done so far. I can take it from here. But I think in your case, you might be one of those people as the transplant pulmonologist that the team should be reaching out to from the hospital, right? As someone who would have an important longitudinal primary care-like role with your patient because of the complexity and how you follow them. And so sometimes I think it's helping the patient know really who are their core team members. And if you are one of them and their primary care doctor is one of them, really kind of how the patient aligns. And not that you'll be able to personally call every primary care physician for all of your patients in clinic, for instance. But, when are the times that it's useful to reach out? And, for instance, if you notice that a patient seems more depressed and you talk to the patient about that, and, I've had specialty colleagues reach out to me and say, I'm really worried about so-and-so, and I encouraged her to reach out to you, but I wanted to tell you what she shared that I was worried about. And the other thing is sometimes I think, especially, you had mentioned earlier, kind of how we think about primary care in the system. I think sometimes even the way specialists talk to my patients about my role in their care really matters, and how we think about primary care, so that my patient will come back and say, oh, my specialist said you were really the expert to ask on this, or my specialist said how it was really important that I should tell you that they started this new medicine because you're the one who monitors all of my medicines and how they impact me. And so that can really, I think, elevate the role of the primary care doctor or primary care APP on the team. So just some other thoughts to add.
My name is Mary Molati. I'm just graduated medical school. I'm going into a primary care internal medicine residency.
Yay.
I really, thank you. I'm here with the American College of Physicians as a health policy intern this summer. But I really appreciated your insights on the value of primary care. And something that resonated with me was the mentorship portion. And part of the reason why I chose primary care was because of one physician who I met in medical school who really saw the joys of primary care. I was wondering, what are the barriers for academic generalists in medical school or medical training to having more of that spotlight and being able to speak about those joys in primary care? And maybe what are some solutions?
Well, I'll say at Johns Hopkins, for instance, my colleague in geriatrics, Colleen Christmas, is now the director of our primary care leadership track. And I think that PCLT embedded in the medical school has been one help. Where I went to medical school, family practice and kind of our outpatient community-based medicine rotation is really where I saw that. But I think the point that you make is thinking about how do we get students exposed, and I think some of it is getting them in to see what we do in primary care. And that house call was so integral for me, and really seeing that relationship between the primary care doctor and the patient and family and what that looked like. So I think exposure to that, and I think that sometimes it's also that we share the frustrations, but really where the joy is, I think, is something I've tried to be much more intentional in talking about. I think also it's, to points my colleagues have made earlier, elevating the value of primary care as something we would match students for mentors, just like we would if they were interested in neurosurgery or cardiology or something else coming into medical school. I think often there's, pipelines for matching for research and those things early on, but perhaps not the same way for primary care specialties. And then part of how we do it is we try to make sure that geriatrics is just in the water. So one of my colleagues is the internal medicine clerkship director, and Colleen, as I mentioned, is the primary care leadership track. And so I think sometimes embedding in some of those roles where students come through can give a chance for that. But welcome. We're so glad to have you.
I'd add that I echo everything you just said, and I'm so excited to welcome you to our crew. I would just add that there are some subtle ways. I like your phrase of putting it in the water. I think I helped to teach a health policy course for Harvard medical students, and one thing that I was noticing is that a lot of the instructors for this course were, in fact, primary care doctors who also did research, and yet there was this sort of absence of language around, or sort of framing of health policy issues to pay credence to primary care as the foundation of healthcare, and a missed opportunity to bring people in. So there was, I remember one moment when I was teaching the small group tutorial where we were talking about Medicaid expansion in states, and this was leading to primary care longer wait times and shortages, and why was that the case? And really, one of the reasons was, workforce shortage. And so the med students were like, why can't we just bring more people into primary care? I turned around and said, well, this is a choice you all get to make, right? So sort of connecting those dots and saying, well, this is they're bringing in the sort of the primary care in these subtle ways into all of the teaching that we do, and not just sort of the same way actually we did with equity, which is another obviously critical topic. We found ways to not just have a dedicated equity lecture, but instead to weave equity into everything that we do and think about it in each of the case studies. So I think primary care deserves and needs a similar treatment.
We need to not use the word just before primary care too. You didn't do that, but all the time I hear people say, I'm just interested in primary care, as if it is in its own, really robust, complex, and rich specialty.
Yeah. I think we're at time. Thank you all for the questions and for listening.
Thank you so much.
Thank you so much.